Hello, everyone. Hi. There we go. That worked. Nice to see you all today. Thanks for coming through the post-lunch slump. I know it can be kind of tough. Hopefully you had some coffee. My name is Avantika Waring. I'm an endocrinologist and obesity medicine physician. I'm the chief medical officer at 9am Health. And I'm really excited to talk about weight health. We're going to talk about GLP-1s. I'm just going to put that out there right from the front. I know many of you may have personal experience. You may be talking about this in your kind of work settings. It's something that none of us can escape, whether you're in the medical field or not. But it's also a really interesting opportunity to talk about how we can provide comprehensive, equitable care to people who live with cardiometabolic conditions. So I'm going to start by just kind of framing for you all what is the problem. I think many of us are now kind of understanding that obesity is a chronic condition. It's a chronic disease. But the way that we've been defining it definitely needs a refresh and an update. So any of you who have maybe worked in the benefits space or yourself kind of navigated how to get a GLP-1 covered know that there are criteria that we fill out. There's a paper that a doctor needs to check boxes on, and typically it just asks, what is the BMI? So that means what's your weight and what's your height, and it's basically kind of a division, and then you get a number. Now, for most chronic conditions, we don't just look at two parameters and decide that you're going to get a medication, and we definitely don't decide that you're only going to be offered one medication. And so that's where I really want to talk about, why do we care about weight? I mean, there's many personal reasons why people care about their weight. But what we want to move towards is a sort of new, more progressive definition of obesity, where we're looking at clinical obesity or obesity as an actual medical condition that needs treatment. And so one of the things you'll see up here is measurement. Now, again, we just talked about height over weight. That doesn't necessarily tell us what somebody's metabolic risk is. And it turns out it's much more helpful to understand where that weight is sitting, where the excess fat is sitting on their body, and how it's impacting their health. And that's really what we should be using to guide our interventions. So something as simple as measuring a waist circumference, which anyone who's got a sewing kit at home with a tape measure can actually do. It's very easy. It's actually super cheap. For some reason, we're not really doing this very often. But there was a recent paper published by The Lancet this year, and they really highlighted the importance of using waist circumference and waist to hip ratios as a better indicator of how healthy someone is. Just to give you an example, at his peak kind of muscle building, Arnold Schwarzenegger had a BMI that was considered in the obesity range. But we all know that he did not have excess body fat, right? So this is more about understanding what the clinical implications are of your weight and less just about checking the boxes for the numbers. Now, many of you are familiar with the metabolic consequences of having high weight. So prediabetes, high blood pressure, high cholesterol, things like that. But there are also some other effects that are kind of less well known. So there's something called the fat mass effect. It's kind of a very sciencey term, but really it just means that because of your body size, you're unable to perform the kind of normal activities comfortably that you should be able to. So that might be like moving through space in your office or, bending over to tie your shoes. It can also be more serious. So some people actually have trouble expanding their lungs enough because of the weight of their body. And these are things that we don't always think about, and they're not always captured on these prior authorization forms or sort of clinical criteria. There are, again, other conditions and disorders that tend to be very high drivers of healthcare costs that aren't necessarily caused by obesity, but are highly correlated with excess weight. So things like depression, anxiety, certain kinds of cancers. And then finally, there's external factors. Sadly, up to 40% of people who live with obesity report having experienced discrimination because of their body size. And actually, it's really sad for me to say that that's often in the setting of a healthcare visit or with a healthcare provider. And so how does that make people feel? They don't want to go to the doctor. It's really very sad. And we'll talk a little bit more about how we can kind of leverage an approach where we're bringing people in for their weight as an opportunity to kind of capture them for other types of care that they really do deserve and have been avoiding. So what makes a successful weight health benefit? So many of you are probably familiar with some of the programs that are out there, but I'm going to kind of highlight for you what the best practices are. Number one, like I just outlined, there are a lot of conditions associated with weight. It's very, very important to work with a program or a physician or a clinical group that understands what those conditions are and how to treat them. So you really need sort of multi-specialty and obesity-specific expertise. I think nowadays everybody knows that lifestyle is, very important. It's been a mainstay, but we're all becoming increasingly aware. Some people really do need medications, and finding a team that can kind of identify who needs the medications and what the right medication is critical. Verified clinical data, that sounds very boring, but what this means is, if you have a program where we're prescribing medications, we're reviewing people's medical history, we're making changes to their entire treatment routine, that really has to be integrated with the rest of their care. So you want to work with a team that really functions like a clinic, and they can help you connect with your primary care, get you referrals to specialists within your network. And that's where I think we make the care very comprehensive and also make sure that we're doing it in a way that's safe and sustainable. So at 9am Health, these are just some of the conditions that we manage. And I know that a lot of weight-specific programs focus primarily on weight. And I understand why someone would do that, but I think it's much better not to silo the weight, right? So we've found in our population, I think about 60% of our members live with multiple other conditions. So that's not just one, but that's two. So you tell me I can just say, if I were going in and meeting with a weight health specialist, and then I was told that actually my blood sugars were high, so I should probably go check in with my endocrinologist, and my blood pressure was high, so maybe I should go see the cardiologist. Well, I would probably just lose my motivation right there. There's a lot of visits to take care of, right? So when we can take care of things that go together naturally, we should. And that's something we've been very, very purposeful in doing in our program. The other thing I'll mention is just screening for these conditions. A lot of folks don't even know that they have these other conditions. So we get people every day who come in because they heard about, Ozempic on TikTok, or someone told them that they should work on changing their nutrition or maybe exercising more to lose weight. And when they come in and we do their labs, it turns out that they actually already live with diabetes or prediabetes. In fact, recently we had a kind of a study cohort. We looked at 7,000 people that came into us, and up to 10% of them, actually, we were giving them a new diagnosis of prediabetes. So they already had some of these conditions and they didn't even know it. And I think this circles back to that sort of healthcare discrimination point I made. People avoid going to the doctor when they feel uncomfortable. And so because weight health is so popular and exciting for people, we can kind of use that as a way to get them in for some of those sort of less sexy, less exciting aspects of care that we really do need to focus on. So what about meds? I'm going to ask a little poll question here. When I say weight loss medication, raise your hand if the medication you think of is a GLP-1, like an Ozempic, Wegovy, Zepbound. Okay. How many of you in this room, and this is not a test, I'm just curious, could name a different non-GLP-1 type of weight loss medication? Okay, those 3 to 5 people, and someone who is like, I'm not sure, maybe I could. And that's okay. So you don't know about these other medications because they are very, very cheap. The pharmaceutical industry has no interest in letting you know about these meds, right? They're not that special. But there are a whole kind of generation of weight management medications that have been around for up to 50 years that can be used safely and effectively at low cost. They're all oral pills. And nobody's using them because we're so focused on the GLP-1s. So it's really important to think about what does an actual obesity-focused practice look like? We are not a one-drug specialty. We have a lot of tools in our toolbox, and part of the kind of challenge and also the fun is figuring out what type of treatment is going to match best with the individual patient. So let's say you have someone who's pretty early in their weight journey, and let's say their weight is kind of on the lower end of the obesity range. Because again, obesity is not just a binary, right? There's ranges of obesity. There's BMIs and waist circumferences that vary across the spectrum. So let's say you have someone who's lower risk. What we would typically do is triage that person to a lower risk intervention. So we'd start with intensive lifestyle change for everyone and maybe pair that with a generic medication and see how it goes. On the other hand, if you have someone who's living with severe obesity, so a higher level of weight-related impairment, we might start them on a GLP-1 more quickly. And then on the far end of the spectrum, bariatric surgery is, I think a lot of people right now are seeing how effective these injectable drugs are, and they think, well, why would I do surgery if I can take an injection? And in some cases, that's true, but there are a lot of cases in which actually surgery is going to provide you with the most durable and effective treatment for long-term sustainable weight loss. So what we kind of comprise our program at 9am Health with is these 4 pillars. So we start with this specialty virtual care, and so everything's done virtually. It's video, phone, text, and I highlight the non-video modalities because a lot of our patients truly have experienced discrimination in a way that they actually prefer not to be on video, especially while they're developing that relationship with the clinician. And then over time, things can open up. And we want to respect that, but this includes obesity medicine physicians, endocrinologists, clinical pharmacists, registered dietitians, health coaches, kind of the whole gamut of everyone who needs to be involved to help support the patient. Labs, we integrate labs, again, for a couple of reasons. One, we want to make sure that we're screening for all these conditions that are often going undiagnosed. And then we want to be able to track progress with our members and make sure that they're meeting their goals along the way. Medications, we've talked a lot about medications already. One of the really challenging things for patients is when they're prescribed a medication that's either off formulary, too expensive, not covered, they have other criteria they need to meet. That can be a real headache. And so one of the things that our platform does is we basically ingest all that information on behalf of the member, and that way we know we're prescribing for them the lowest cost drug within class. Just make it as easy as possible for them to get on the right therapy and then stay on it. And lifestyle interventions, it's the last pillar here, but it's probably the most important. I think one of the things that has gotten so overshadowed, we even get folks come in and say, well, I've done the lifestyle, I just want to try the meds now. But they're not mutually exclusive. And in fact, the best outcomes we see, the people who really succeed on any of these medications are the ones who also at the same time double down and just work with a nutritionist, work with a coach, and make those changes. And that's where you get those very, very powerful results and those stories that are like really impactful. So I think I heard a little bit of AI talk in the last presentation as well. And you kind of can't get off stage these days without talking, at least touching upon AI and how you're using it in your program. And I think AI is a really powerful tool, but given that weight health and nutrition and lifestyle change is so personal, our strategy has really been to leverage AI to make the work easier, more efficient, and more convenient for the team so that we can provide that sort of one-on-one, really personalized, warm human interaction at scale. So, we have this group of specialists, and then we have guidelines, we have the medical evidence. That all gets kind of pulled into what we call our clinical engine. And then we use that to help guide things like triaging patients so that the right patient gets matched with the right clinician or the right maybe customer service person, whatever it might be, the billing department, based on their kind of question or need. And then on the other hand, we use AI to help support the clinical decisions that our team is making. So for example, surfacing all the information in a way that makes it very, very easy for the clinician to make the right decisions and to be consistent in the care of the patient. But I don't think at this point, especially for weight health, it is so tied into emotions and past history that we can do without that human connection. I'll probably be up here in, I don't know, maybe 2 or 3 years saying something different, so we'll see. But right now I feel like our members really, truly appreciate the ability to talk and connect with another person who wants to hear them out. On the lifestyle side, so many of you, actually, has anyone here worked with a nutritionist in the past? Gotten a meal plan? Yeah, great. So many of you have. And even just in my own experience, it's one thing to tell someone, okay, let's swap these 5 things for these 5 things. Let's have you eat more salmon and quinoa and less, frozen pizza. I'm just giving examples of things I see in my fridge. But telling someone to do those things and actually having them do them is very different. We're all busy. And then if you have to create kind of meal plans and nutrition changes for not just yourself, but likely your whole family that you're feeding, that can be very, very overwhelming. And so we saw this as a gap, and that's where we added a meal planning function within our app. So members can basically go in and sort of report out their preferences, whether it's just a taste preference or a cultural dietary limitation, whatever it might be. And this actually also leverages AI to generate these meal plans that are aligned with your nutrition goals and informed by the dietitians. And then that just kind of helps take away that last step for the member. I mean, really what we should do is like send someone to go home and cook it for them, but maybe that'll be version 3, who knows. For now, they still have to cook their own food. But just providing every support we can to help people make these lifestyle changes has been really, really helpful and empowering for patients who previously might have said, well, I know what I'm supposed to eat, but I just can't figure it out, or I don't have time to cook. So this is not intended to be a pun, but I realize it is. When people are thinking about, like, should we offer GLP-1s to our population? Should we offer weight loss meds in general to our population? I like to think of it as the pros and the considerations, not the pros and the cons, because I don't really think there are cons beyond sort of, honestly, financial implications here. On the pro side, like it would be disingenuous for me to tell any of you that you can start offering GLP-1s tomorrow and you will immediately start saving money. That's just not the reality. The drugs are very expensive, and it's an investment that you do have to make. But what I will say is that there's an increasing and growing body of evidence that by helping people lose weight in a sustainable way and with the right medical support, it will save money on medical costs. We know that the annual medical cost for someone who lives with obesity is anywhere from $1,800 to over $3,000 more per year. And of course, it's higher the higher their body mass index is or the more severe their obesity is. So we know that these folks are costing health plans and employers more. And we also know that with weight loss, we do see a decrease in the monthly medical spend for people. And again, that is highly dependent on who you're picking, to qualify for these meds. Someone who has a mild obesity, doesn't have any co-conditions, they might feel better, having lost some weight with the medications, but you're maybe not going to see the same kind of ROI as you would for someone who's got multiple chronic conditions and severe obesity. That kind of makes sense. The other thing I'll just mention here, I know we have a lot of HR folks in the room, so people will stay. It's a huge satisfier for an employee to have access to the medications and consistently. So, a survey showed that 35% of Americans who were polled actually said they would stay at a job they didn't like because it was covering their GLP-1, which is, unfortunate, but also something to think about. Like, this is something that people really value, and it's very, very hard when people change jobs and they lose coverage to kind of go on and off. So it's something to think about. On the consideration side, kind of what I alluded to earlier, the medical cost savings, and this is proven in the data, they are going to be greater if you really pick the right population. And that's where working with an obesity solution, like a program, versus just traditional criteria, it can help. Because, for example, at 9 a.m., we'll look at all of these factors. So what is the actual weight? What conditions do they have? Are they severe conditions? Are they mild conditions that are likely to respond to lifestyle only? That's how you're going to really maximize the value and also have the opportunity to help people who need it the most. The other thing that I just want to bring up, I've been talking about GLP-1s, but I also just said that there are a bunch of other meds out there. So, we have clients who say, well, we want to help people lose weight, but we just cannot imagine footing the bill right now for these expensive medications. You can certainly implement a weight health and obesity management program without GLP-1s. Maybe that's how you start. But again, we can support people in that really essential lifestyle change and offer them the first generation medications. So it's really giving people access to an obesity center of excellence or an obesity clinic that maybe just doesn't cover the GLP-1s, and that's perfectly valid. We can get clinically significant metabolic improvement and weight loss that way as well. And finally, I do like to bring up this point. Many of you who, anywhere you work, if GLP-1s are not covered, people will go out and buy them themselves. I'm sure most people in the room know someone who's paid cash for a GLP-1 somewhere. And this does result in a bit of inequity, right? Because you're in an employee population, you've got people who can afford it and people who can't. And often the people who can't afford it are the ones who need it the most. So I do personally feel that offering GLP-1s in a conservative and controlled fashion as an employee benefit is a real health equity booster because you're actually providing access to everyone who needs it based on clear medical criteria and not based on, well, I have extra money, so I'm going to go ahead and buy this for myself. So some of that is just something to think about with your population. So really what we're trying to do at 9 a.m. is bring all of these components of care together. And I do think that that provides a really great experience for people that helps them to be successful, not just in the short term, but in the long term. And I think I'm actually out of time. So I am going to stop right there. Thank you.